is really, really common. 30% of females in their 30s and 40s are going to have quite significant acne.
I think it's a really cruel thing for many women. First appears when they least want it. They may be progressing their careers,
Getting
married, maybe they're about to have children or expand their families, and they're experiencing acne that can be painful, unsightly. It gives us something to actually pin a lot of their concerns on rather than just blaming themselves.
Hormonal acne. We're going to be talking about how it happens, who it affects.
Why do you get it and how do you treat it?
Hi Ryan, hormonal acne. What is it?
It's so common, isn't it? We get asked about it all the time.
Yeah.
And I really explain to patients that all acne is hormonal, right? It's driven by androgens, which are male hormones. Something that
we all have.
We all have them. So this is where it can get confusing because sometimes when I say this to females, to either young girls or older ladies, I say, look, it's driven by male hormones. They sort of look at me as I'm a bit strange.
Yeah.
But I explain that regardless of whether you're male or female, we produce male hormones.
Yep.
In women, these male hormones are produced by the ovaries and the adrenal glands. Mm-hmm. And in men, they're produced by the testes and the adrenal glands as well.
Mm-hmm. And so it's not that these hormones are particularly high or out of range. It's just that the oil glands are a bit more sensitive to these hormones.
Yeah, well, in some cases, it's just that genetic hypersensitivity to male hormones. But in some cases, there are actually elevated amounts of male hormones being produced. And it's these patients that we are particularly interested in doing proper investigations and tests for. But for the majority of patients, particularly women in their 20s, 30s or 40s, they're often normal. So as you said, it's that genetic sensitivity to normal levels of male hormones.
It's a pretty problematic age, really, to be presenting with acne. And I find it is really, really common. Like the numbers are 30% now of females in their 30s and 40s are going to have quite significant acne. Are you seeing that in your practice as well?
Absolutely, absolutely. And I think it's a really cruel thing. It's sort of, for many women, first appears when they least want it, right?
I know, that's so unfair.
That's right. They may be progressing their careers, getting married, maybe they're about to have children or expand their families, and they're experiencing acne that can be painful, unsightly, really affects self-esteem and mental health as well.
It really does. And I find this sort of acne does tend to be deeper, more cystic. So as you said, more painful and often more debilitating than teenage acne in a way.
That's right.
Do you have any modifications to your teenage regime that you carry over into managing adult acne, or how do you approach it?
Really good question. And I think it's about understanding for that person in that particular phase of life where they're at. Because with that truly hormonally driven acne that tends to fluctuate with the menstrual cycle or has come about because they've jumped off the oral contraceptive pill.
That's a really common one.
We find that often they'll need oral medications. We call them systemic medications because often the creams, the lotions and the potions or the skincare that we may use in our teenagers doesn't necessarily cut the muscles.
Does it?
No, that's right.
And it's really that time frame too, isn't it? And being aware that it might actually be 3 to 6 months of sitting through coming off that pill to reestablish a hormone profile. And that's when you need the support of these extra tablets. Are you talking things like spironolactone?
Yeah, so we're definitely thinking about tablets such as spironolactone, as well as isotretinoin, so vitamin A-based medication. Question for you, Kate, is what do you explain to your patients as to why they're getting their hormonal acne or their acne after jumping off the pill, the oral contraceptive pill?
That's such a common question. I find a lot of my patients are so frustrated and it's often been a decade or more of being on the pill and they can't actually even remember why they went on the pill in the first place. But often in a teenager or late early 20s, part of going on that pill was their acne. So I explain that when you've taken away something that was dampening down that oil gland, just not entirely, but a good 30% of that oil gland flow, then now you've reopened that. So the skin's really readjusting to an accelerated oil flow and not coping with it. So then we look at often adding in a really good cleanser, a salicylic acid containing cleanser that unclog the pores, making sure they've got a good stable moisturizing routine, and of course the sunscreen.
That's right. I think skincare is definitely important for this.
Essential, really.
Yeah, absolutely, for this patient group. I think it's really important to explain to them that actually they've had the genes for acne their whole life.
Yeah.
And often they've looked at their parents, maybe their brothers or sisters, and they've often also suffered from acne.
Yeah.
And now these genes are really activated, coming off the oral contraceptive pill, which is really cruel.
Yeah.
But we can't change their genes.
No.
Right? So we are going to offer them long-term treatments, which again is tricky based on if they are planning to start a family, because not all medications are safe. I find a really important group of patients to talk about are those that have been previously labelled having had PCOS or being diagnosed with PCOS.
Yeah, what is PCOS again?
Well, this is a really good question. And funnily enough, it's really just very recently been renamed. So it used to be called polycystic ovarian syndrome.
Yes.
But very recently, there's been a whole worldwide renaming of this condition.
It was quite a campaign.
It was.
Yes.
And now it's called PMOS.
Okay.
So PMOS stands for polyendocrine metabolic ovarian syndrome. So quite a mouthful.
Yes.
Much easier to say PMOS.
But better reflecting probably the endocrine drive of the disease rather than an ovarian issue.
That's right. And particularly that lack of or the emphasis on cysts of the ovaries.
Yes.
Because how common is it for us to see patients?
We never found the cysts when we did the ultrasounds,
That's right.
did we?
No. And so a lot of young women or older women will come to me saying, oh, no, I had an ultrasound and they didn't see cysts on my ovaries, so I don't
have it. Exactly.
That's right.
Yeah.
So what this new diagnosis of PMOS actually reflects is that you don't have to have cysts on the ovaries. That's just one of the diagnostic criteria.
Right.
But you have to have either what we call clinical features of excess male hormone. So that means acne, which is why they're seeing us.
Yes.
Maybe some hair loss and excess hair growth as well. That's sort of, particularly around the chin.
Which is really common as well.
Super common.
Does the acne have to be necessarily severe to give them that criteria?
It doesn't. So any degree of acne is enough to make that diagnosis.
Yeah.
And in some women, they may not even have acne, but they may truly have elevated male hormones on their blood test.
Yes.
The second diagnostic criteria that people often have is irregular menstrual cycles. Even that's a little bit tricky because some patients with PMOS have very regular periods, but they're not actually releasing an egg each cycle.
Or they have an intrauterine device as a contraception, which can make it tricky too.
That is masking it. So all of these things have to be off all contraception, like the Mirena or the oral contraceptive pill.
Yeah.
And the final criteria is, cysts on the ovaries or a blood test called the anti-Mullerian hormone. And you need 2 out of 3 of these to qualify for this diagnosis.
Official diagnosis.
That's right.
Does that change your management particularly?
It's a really good question. It doesn't necessarily change management, but it does change what I'll tell them is their risk of getting acne back in the future.
Yes.
So I'll say to them, when you have that genetic predisposition to being really sensitive to your hormones, whether it's elevated or not, it means that most likely we'll need you on long-term therapy because I can't change your genes.
Yeah.
Right? So often, and that's quite sad for a lot of these patients.
It is something hard to swallow, isn't it?
It is.
Yeah.
It's saying that, I'm committing you to long-term medicine.
Yeah.
It's frustrating.
Yeah.
Totally accept that. I'll often tell them that when we've treated them with medications such as isotretinoin, so that's that vitamin A derivative, they're more likely to get their acne back after the finished treatment. And it may mean
often less severe, I think.
Often less severe, definitely.
Prognostically, I think that's really positive.
Absolutely. Yeah.
To know. Yeah.
Totally agree. I think we can still make a huge difference to these patients' lives.
Yeah.
But just to know that they're going to have that genetic sensitivity long term, they'll probably need some form of long-term treatment. And sometimes there's creams. They'll just need to manage their skin with good quality retinoid creams and maybe some topical anti-male hormone creams as well.
Yeah, I think that's really important to know the likely lie of the land coming forward. I think a lot of these women as well are planning pregnancies, and pregnancy can really wreak havoc with skin, as you know.
Yes.
But I do find a lot of these patients do better in pregnancy.
Yeah.
So that's something as well.
It's positive. Absolutely.
Yeah.
I think also, Kate, it's really important to realize that when you have a diagnosis such as PMOS, it's more than just about the skin. It's about our metabolic health. So that's thinking about things like our cholesterol.
Yes.
It's our blood pressure.
Yep.
Our risk of type 2 diabetes.
And glycemic control.
Exactly.
Yeah.
And it has a whole lot of implications for fertility, for our mental health, and
chronic inflammatory diseases as well. And I think these patients are really well placed to be earlier risk identifiers for these diseases. So in a way, while it is hard to be diagnosed with a chronic disease, there's also some pluses, because if you can rectify those risk factors early, you've got so much better chance of controlling things and of preventing other diseases down the track.
Absolutely, which is exactly why I love chatting to you, because this is what we're here to do, is to provide our patients and those who may not necessarily get to see us with really good information.
Yeah.
We're going to send some links or include some links below that you can read more about this diagnosis and have a really good chat to your general practitioner about it.
Yeah.
Because it really has so many implications for our general health, including our skin.
So once you've got these patients well established on a treatment plan, and that can often include medications. What is your advice surrounding diet?
So I think diet plays a really big role in this group of patients because we know that they're more at risk of having other problems, including high cholesterol, insulin resistance, and type 2 diabetes.
Yeah.
So we know that not all patients with PMOS will necessarily be overweight or obese. Can definitely be pretty slim and slim build and still have PMOS. But the reason diet's so important is because of insulin. So this is where that polyendocrine component of PMOS is so important, because insulin is actually responsible for a whole lot of problems.
It really is, isn't it?
Absolutely.
So much more than we realised. I think it's just being discovered that this hormone can actually cause so many systems.
That's right.
A really pathological state. So
totally. So I often say to patients, look, with this diagnosis comes a responsibility to be really have a really healthy, balanced diet.
Yeah.
We know that the evidence suggests that a high protein, low carbohydrate diet is particularly helpful. We really want to boost the protein, have low glycemic index foods, so that cutting out or really reducing refined sugars.
Yep.
The really starchy foods, so
the processed foods.
Yep. So white bread, rice, noodles, and pasta. As much as we love it,
yes,
I certainly do. It's really can be quite challenging because you need to keep them low and incorporating a good exercise regimen as well. Because what we do know is that when you carry a little bit more weight around your midsection, that fat that's there is not just sitting there. It's actually very pro-inflammatory. So insulin, which helps us grow that fat, which is very frustrating, is actually going to drive more inflammation in our body generally, not just our skin.
So it's breaking that cycle, really.
That's it.
So
that's it.
It definitely goes beyond the skin, doesn't it? And the effects, hopefully, will be seen everywhere. What about impact on mental health? I have so many patients coming in with hormonal acne that it's so detrimental to their relationships, to their self-esteem, just to their general confidence. I think what you raised earlier about being on alert for other body systems and helping in such a multifactorial way can be really beneficial to mental health. Is there anything else you think we can add in?
I definitely think so. And I think what this diagnosis does, as you mentioned, is empowers us because it also removes that sense of blame.
Yes.
A lot of these patients have been fat shamed over the years. A lot of them have very low self-esteem because they've struggled with weight, they've struggled with their skin. Potentially they're losing some hair as well. And it's all related. And I explain to them, it's really not your fault.
No,
right?
It's nothing that you're doing.
It's nothing that you're doing.
Your genes.
It's the genes.
Yeah.
And unfortunately for these patients, they'll have to work harder than the average patient to make sure that their diet's really on point, to make sure that they're building in that good exercise regimen. But it gives us something to actually pin a lot of their concerns on rather than just blaming themselves and feeling awful about themselves.
And I think the recognition of the interlinking of all of these things is so helpful in making a plan to going forward.
Yeah.
Let's jump into fact or fad.
Let's do it.
Hormonal acne. Ryan, hormonal acne only happens right or during your period.
Fad.
Dairy causes hormonal acne because of the added hormones that are in cow's milk.
Fad.
High stress and high cortisol levels are the primary root cause of hormonal acne.
Fad and fact, not primary, but definitely relevant.
If you have hormonal acne along your jawline, it's a definitive sign that you have PCOS.
Fad.
The pill can both cause and treat acne.
Fact.
If you want a full breakdown on any topics we've discussed in a bit more depth, just head to our YouTube channel.